This week on the BackTable podcast.
Giving someone a penile prosthesis because they have erectile dysfunction is gender affirming care. But specifically, things for gender diverse persons can definitely be done by a general urologist. Urologists can do orchiectomies for trans women who are interested in that as either a starting point for their surgical care or even a final surgery for themselves. They may not be interested in a vaginoplasty or a vulvoplasty going forward. A lot of general urologists also offer testosterone therapy to their cisgendered patients, and that's certainly something that you can offer to transgender patients as well.
Welcome to BackTable Urology, everyone. I'm George Koch from The Ohio State University, and I'm really excited to introduce one of my partners at The Ohio State University, Dr. Eric Walton, today to discuss gender surgery and its growing place in urology. Thank you so much for being here, Eric. I really appreciate it.
Oh yeah, happy to be here. Thanks so much for the invite.
Of course. Can you start by telling us a little bit about your path to reconstructive urology and gender surgery?
Yeah, sure. So, well, to be honest, I didn't think I was going to be a surgeon, but then I fell in love with the OR and all the technical aspects of surgery. And actually, my first exposure to urology was pediatric urology, and there's a lot of overlap there with reconstructive urology. And as I was in medical school and residency, ultimately I found that what I most enjoyed about urology is improving people's quality of life, and however that might be defined for a patient. And I found that reconstructive urology was really the perfect fit to provide that care to patients. With respect to like gender surgery specifically, that kind of brought together a interest of mine that was there before I even started urology, which was an interest in health disparities and access to care. And when I was looking for opportunities as a resident to work in that space, I discovered gender affirming surgery. We didn't have any exposure to it in residency, but I thought it was a good marriage of the technically interesting work of surgery, improving quality of life for patients, and then working to expand access to care for underserved groups.
Okay, I hadn't heard that before. So from an access to care standpoint, can you talk a little bit about the gender diverse community and what troubles they face with access to care? I know we're skipping around a little bit, but since you bring it up, I think it's a really great point.
Yeah, absolutely. So we know that gender diverse individuals, whether they identify as transgender, non-binary, or another identity, we know that they're generally underinsured. So just getting access to care in general is a problem. And then from a surgical perspective, there's still not that many providers throughout the country or even worldwide who are offering this care. And so they might have to travel outside of their state or outside of their country to even access that. So training to do this work by increasing the number of people who are offering surgery is increasing access of care for patients.
Yeah, absolutely. And hopefully a little later on in the conversation, I'd love to talk a little bit more about ways that we can kind of expand access for these patients. One thing I was hoping to, for those listeners who maybe aren't urologists or who are medical students thinking about urology, or who are urologists that trained, a few years ago, maybe when there were fewer gender surgeons, spread throughout the country. I was hoping you could talk a little bit about what specialized training in gender actually looks like, just so that we can kind of all be on the same page.
Absolutely. So like you mentioned, it totally depends on the person. If you're someone who is a little bit older than I am, there were no opportunities for formal training. So you would go and observe other surgeons who were doing this work already, or you go apprentice with them for a period of time and then bring these surgeries back into your practice. But we are now seeing an increase in the number of formal programs providing training in gender affirming surgery. These are mostly 1 or 2 year fellowships. So they're going to be done after you do a 5 to 6 year urology residency, or you can access these fellowships from a plastic surgery or general surgery, sometimes pathway. Some of these programs are going to be GURS programs. So you're going to see other reconstructive urology procedures. Of course, for anything that's top surgery, it's going to be more of a plastic surgery fellowship training. And then there is a little bit of overlap with FPMRS, but I think more of the more formal programs are coming out of the GRS pipeline.
So thinking about ways to kind of break it down, it sounds like you can do it a bunch of different ways. You can do it training pathway, plastics versus urology. You can do it top versus bottom. I'm sure within the GERS community, and I mean, you can talk about that a little bit more. There's even the various fellowships that are available are probably have a different focus even within gender surgery. Maybe touch on that a little bit. I'm thinking robotic versus open, masculinizing and feminizing versus just feminizing. I don't know if that's kind of a focus. Maybe I'll let the expert talk about it. Yeah. Here, and I can read you that question too. That's perfect. Love it. Okay, so from kind of a understanding the various pathways and breakdowns of fellowships, it sounds like you can have a top versus bottom focus, a plastics / general surgery versus urology focus. Within urology, I know that there's both open and robotic approaches to some of these surgeries. So maybe talk a little bit about kind of how we've broken it down within urology.
Yeah, absolutely. So
a little bit more about ways that we can kind of expand access for these patients. One thing I was hoping to, for those listeners who maybe aren't urologists or who are medical students thinking about urology, or who are urologists that trained, a few years ago, maybe when there were fewer gender surgeons spread throughout the country, I was hoping you could talk a little bit about what specialized training in gender actually looks like, just so that we can kind of all be on the same page.
Absolutely. So like you mentioned, it totally depends on the person. If you're someone who is a little bit older than I am, there were no opportunities for formal training. So you would go and observe other surgeons who were doing this work already, or you go apprentice with them for a period of time and then bring these surgeries back into your practice. But we are now seeing an increase in the number of formal programs providing training in gender affirming surgery. These are mostly 1 or 2 year fellowships. So they're going to be done after you do a 5 to 6 year urology residency, or you can access these fellowships from a plastic surgery or general surgery, sometimes pathway. Some of these programs are going to be GURS programs. So you're going to see other reconstructive urology procedures. Of course, for anything that's top surgery, it's going to be more of a plastic surgery fellowship training. And then there is a little bit of overlap with FPMRS, but I think more of the more formal programs are coming out of the GRS pipeline.
So from kind of understanding the various pathways and breakdowns of fellowships, it sounds like you can have a top versus bottom focus, a plastics / general surgery versus urology focus. Within urology, I know that there's both open and robotic approaches to some of these surgeries. So maybe talk a little bit about kind of how we've broken it down within urology.
Yeah, absolutely. So if you're coming from a urology background, you're probably not going to end up in a program where there's a lot of top surgery. But if you did go to a plastics route, you may get some exposure to top surgery. I pursued something that was focused on bottom surgery. But like you said, there's lots of options there. So some programs you're going to see more diversity. You're going to see both masculinizing and feminizing procedures. Within the feminizing procedures, some people do vaginoplasties from the robotic approach. Other people are doing it from an open perineal surgery approach. And there are people who will do both, but the majority of your training is going to be one or the other, probably not 50-50. I also think it's important to look at the case mix. So I chose a fellowship where I could get at least 50% or more of my time focused on gender affirming surgery. But there are definitely GERS programs out there where you're going to get some exposure to these surgeries. Maybe it's just going to be taking care of patients who had complications or doing a smaller handful of cases over the course of the year. And so I wanted a place where I could really focus on gender affirming surgery as a major part of my training. If you're coming from a urology background, you're probably not going to end up in a program where there's a lot of top surgery, but if you did go to a plastics route, you may get some exposure to top surgery. I pursued something that was focused on bottom surgery. But like you said, there's lots of options there. So some programs you're going to see more diversity. You're going to see both masculinizing and feminizing procedures. Within the feminizing procedures, some people do vaginoplasties from the robotic approach. Other people are doing it from an open perineal surgery approach. And there are people who will do both, but the majority of your training is going to be one or the other, probably not 50-50. I also think it's important to look at the case mix. So I chose a fellowship where I could get at least 50% or more of my time focused on gender affirming surgery, but there are definitely GERS programs out there where you're going to get some exposure to these surgeries. Maybe it's just going to be taking care of patients who had complications or doing a smaller handful of cases over the course of the year. And so I wanted a place where I could really focus on gender affirming surgery as a major part of my training.
Mm-hmm. Yeah, and I very much get that. I was at the University of Washington for training, and maybe a tenth of my training, let's say, was gender affirming surgery. There were some opportunities to do fallow, but because of the way that kind of cases got distributed and scheduled, I pretty much only did vaginoplasties. I feel like from a technical standpoint, I could get through a vaginoplasty with that type of training, but I very much get what you mean as far as wanting to focus on gender surgery specifically, if that's what you're going to be doing with your career, because I certainly wouldn't say that I prepared to do a vaginoplasty in practice. I think I could do one that's well set up with somebody over my shoulder, but understanding the appropriate WPATH criteria, the counseling, the endocrine, all of that, I think really is something that you need a significant amount of training to be able to really do the right way.
Absolutely. I think you need to be able to identify and handle the complications. You can't prepare for every complication, but you want to at least have some exposure to them in training if you're going to make this a big part of your practice. And I think that because there is a bit more collaboration with plastic surgery on the phalloplasty cases, that can be more limiting in the training opportunities because you need to have both programs up and running well.
Gender surgery, it's been around in urology, I think, for a long time, but I think it's really in a period, at least my perception is it's in a period of kind of rapid evolution and dissemination within urology. I was wondering, from your perspective, what does the gender affirming surgery landscape look like right now in urology? What kind of institutions are doing it? Are people doing it in community practice versus academics? What aspects of gender care being done by specialists versus reconstructive urologists? I know I'm not supposed to stack questions, but there they all are.
Yeah, I think those are all great questions. I think it's both an exciting and fragile time to be working in gender surgery. There's a lot more opportunities to join programs where there is either a full framework or at least a partial framework for this care, so you're not necessarily starting from zero. There's also a lot of interest from academic institutions to open centers for excellence in this care. I think historically it's reasonable to say that most gender care was being done in private practice settings, in the specialized private practice settings, and it's now starting to shift where you can pursue care at a center of excellence that's academic, where you have all services in the same building or at least the same institution under one roof, and it's all patient-centered collaborative work. So I think going forward, you're going to see that increasingly this is happening at academic institutions. I think one of the reasons for that is what we talked about earlier, which is access to care. And in the private space, people are running a business. They still have to, pay their employees, pay their bills, feed their family. And so they can only take self-pay or insured patients. And often that means that Medicaid, Medicare patients are not going to get care in the community. That doesn't necessarily true across the board, but I think patients that are underinsured are going to be coming to academic institutions.
That sounds like a pretty big dichotomy between, what gender care looks like from a private practice standpoint and what it looks like from an academic standpoint. I don't know that I had thought about it like that before.
Yeah, I think that the care can be potentially a bit more streamlined if you're coming to an academic center where we can provide all the resources in the same place and coordinate care for you. I think that patients that have historically gone to private practices, there's a bit more legwork on their end. And I think those practices are great and they're doing good work, but it can be challenging for patients who don't have the means or the health literacy.
Mm-hmm. Yeah, absolutely. Are there, we've talked about specialized private practices and we've talked about academic institutions. What about like a general urology practice? Are there aspects of gender care kind of in the current landscape that are being done by someone who's also treating BPH stones, ED, doing a prostatectomy a couple times a year? Is that happening right now, do you think? I know you don't work in all these practices.
No, of course, absolutely. This is definitely happening there. And I always like to say that lots of urologic care is gender affirming care, even if it's not for gender diverse persons. So giving someone a penile prosthesis because they have erectile dysfunction is gender affirming care. But specifically things for gender diverse persons can definitely be done by a general urologist. Your general urologist can do orchiectomies for trans women who are interested in that as either a starting point for their surgical care or even a final surgery for themselves. They may not be interested in a vaginoplasty or a vulvoplasty going forward. A lot of general urologists also offer testosterone therapy to their cisgendered patients, and that's certainly something that you can offer to transgender patients as well.
And from a general urology standpoint, what resources are available for a general urologist who does want to provide gender affirming care to a gender diverse population, who does want to do orchiectomies or testosterone replacement? What kind of guidance do they have if this wasn't something they did in their training?
Yeah, absolutely. Great question. I think there are a couple versions that are being used right now. Standards of Care 8 is the most recent, and it is the most flexible of the guidelines because it's targeted at a global audience with different legal barriers that may be in place. Standards of Care 7 was a little bit more rigid, and so it's often used by insurance companies when you're looking for the proper documentation for insurance coverage of these procedures. So I think that's an important thing to consider. And then secondly, this is a multidisciplinary care space. And so you'll be needing to get letters of support for patients from mental health providers and or hormone prescribing physicians. And so I would lean on those providers heavily, especially during your initial evaluation, because they're going to know the patients the best. And they've been working with these patients a lot longer than you have when you see them for a consultation the first time.
Yeah, absolutely. And I mean, even just talking about that, you can see how an academic institution might kind of bundle and coordinate folks' care. It might be a little bit more difficult on the private practice side, but still very, very doable, I think.
Yeah, very doable on the private practice side. And the thing that I have noticed about our patients who come to us for this care is, in general, they're very savvy and they know how to navigate the medical system. They know what they need. They have large online and in-person communities that they can lean on to understand where is safe to go, what is needed for me to get the care that I need. So they often come in and they generally know what they need to have done before they can have surgery.
Gotcha. Prepped and ready to go, kind of.
Prepped and ready to go. They may not have their letters updated or signed. They may not have done their hair removal yet, or they're looking for resources for hair removal. But in general, they have an idea of what is required by them to get surgery.
Gotcha. Which makes sense. I mean, if you're thinking about a savvy, forward-thinking patient group, you're probably thinking about a group that wants to meet their surgeon, earlier in the journey than like when it's time to get surgery. That makes some sense to me.
Yeah, they're coming in ready to go, at least mentally.
Yeah, absolutely. So you've recently, finished training and started practice here at Ohio State. Tell us about how you're going about building a gender surgery program or incorporating, gender affirming procedures into your practice as a new attending.
Yeah, absolutely. So I'm lucky that at The Ohio State University, we have a history of a gender affirming care team. And there was another provider who was here a few years ago who had done some of the groundwork for me. So I'm not starting from zero. We just had to restart some of the things that are going on. But even with that, you still have to just like with when starting a new practice, you have to grow your referral network. You have to make sure you're doing proper patient selection and build a professional reputation so that people will continue to want to come see you for care. I think that what's most important for building a gender affirming surgery program is connecting with other physicians who you can collaborate with to build a comprehensive program. So connecting with plastic surgeons who can help you with phalloplasty, connecting with behavioral health providers who you can get patients in with to get an additional letter of support, get evaluated for surgery and get that extra letter of support. People from the primary care side who are providing HRT and connecting with primary care doctors who are providing hormone therapy or just providing general primary care to gender diverse patients and having them know to send patients your way so that you can talk to them about surgery. One thing that is really helpful, both here at The Ohio State, as well as where I did fellowship at University of North Carolina, Chapel Hill, is having a nurse coordinator who can really kind of triage requests and referrals for surgery and connect me with different resources in the hospital as well as the community. I think it's been really important to me to be thoughtful and respectful about how I introduce myself to the gender diverse community here in Columbus, Ohio. I don't want to show up and just market myself as a surgeon who I don't want it to come off as commercial. So I just want to find ways to connect with and interact with the community here that I'm not formally a part of because I'm not from here and I don't identify as transgender or non-binary.
And have you had challenges thus far? What are some of the unique challenges you've had early on?
I think one of the challenges that can happen when you're early on in your career, especially at a academic place, is that you're only going to get access to a certain amount of block time. So you may be seeing patients for surgery consultations, but I can't promise them a certain date, especially because some of these cases will take 6 hours. And so that means I have to get a full day of block time, which you may not have a ton of upfront because you're building a practice. Another thing that I think about a lot that I don't think I would think about if I was maybe an oncologist or even a general urologist is that I need to work closely with the pre-certification team to make sure that my surgeries get approved. There's a whole list of things that we need to provide to insurance companies to demonstrate need, and we've gotten good at that. And because The Ohio State has been doing gender affirming surgery for a period of time, they're familiar with what we need to send along, and it's a successful process. But you have to be thinking about that upfront and how far out do I need to book these surgeries to make sure that we're not going to be in a tricky space financially for the patient.
Yeah, absolutely. One thing that I'm sitting here as I'm listening to you think about your challenges and thinking about, what challenges I would anticipate or worry about as I was starting a gender practice is probably your staff, your schedulers, the nurses. That's a whole area of the clinic where when I came in and started my practice, I don't know that I necessarily had to educate someone on how to talk to a urethroplasty patient. Could you talk a little bit about that? I think that might be really applicable to some of our general urology listeners who, if they do want to provide gender affirming care, probably have to have their head on a swivel a little bit to make sure that their kind of whole operation outside of the medical piece is doing the right thing for these patients.
Yes, 100%. Yeah, our care team includes all of our nurses and MAs and our front desk staff. So we want to make sure that when a patient calls in, that they're getting gender affirming care from the start to finish. We want to make sure that they're being addressed with gender neutral or gender affirming pronouns, their proper name, making sure things are updated in the EMR to reflect that information so that our staff doesn't accidentally use the wrong information. These procedures I always like to tell staff that the postoperative care is not as intimidating as it sounds like, but you do still have to familiarize the triage nurses with what types of calls you're going to get. How can you, I like to kind of compare the calls that they're going to get to other surgeries that we do so that they know, oh, it's similar to this surgery, so I can think about it like that. Or it's similar to vaginal surgery. So if they're calling about vaginal bleeding and it's just spotting, I know that's normal because I know how to triage other vaginal bleeding calls. If they're calling about urinary retention, well, urinary retention is still urinary retention, so I can still think about it that way. And so kind of breaking it down to symptoms for them and making it less intimidating I think is the way to go about doing that.
Yeah, absolutely. It's not, it's not a different system, a body system. It's still urinary retention. It's still post-op pain. These are things that they take care of probably every day. A lot of times, maybe even without us even hearing about it because it goes well. So maybe reframing it as this isn't gender affirming care. This is someone calling about post-op urinary retention.
Yes. And I think it's also helpful for me it's helpful when the staff is familiar with reconstructive urology patients in general, because I think reconstructive urology patients maybe call the office a little bit more than general urology patients. And so reminding them that they're pretty similar to any other reconstructive urology patient and to treat them that way as well.
Yeah, absolutely. For those listening in institutions, without an established gender program, what would your advice for laying their own kind of groundwork be? Either, things that you're happy that you had because, Ohio State had a gender program prior to you arriving, or things that you've learned since that you wish they had prior to you arriving?
Yeah. So, I mean, going based off of what I know from starting here at the Ohio State and knowing what it took to start the program at University of North Carolina for my mentor, first and foremost, it's the most important thing is being self-motivated and excited to put in the hard work to push something forward, because it's going to take time and a lot of energy to grow a program. It's also hugely important to find a group of collaborators and the other crucial specialties that are going to be able to help you move something like this forward and bring in more patient referrals and spread the word. And then ultimately, if you can find someone like a nurse coordinator to really put all the pieces together, they're going to be the linchpin that helps the program grow and become as big and great as it should be.
Yeah. You mentioned their mentors. Talk about mentorship, because it seems like, we're talking about gender surgery and urology expanding, but I do think it's still relatively a small community, at least of thought leaders. How can a resident, a fellow, a young faculty member find mentors or training opportunities?
Yeah, I agree. I do think it's a small community, but I also came from a institution that didn't do gender affirming surgery, and I was able to make connections to make it happen. I think because urology and reconstructive urology is such a small field, anyone that you work with is going to know someone who knows someone who's doing gender surgery. And from everyone that I've met and everyone that I've talked to, we're all very willing to talk, have a conversation, to invite you to come see what we're doing, to open the door for you. So I think the first thing, the most important thing you can do is ask someone that you know to help you get your foot in the door.
Yeah, that's definitely true. I don't do gender surgery in my practice, but I can think of a bunch of people who, if a student came to me, and I would have them reach out to, now you as well. But even before you started working at Ohio State, I think everyone's personal network definitely includes, a gender surgeon within reconstruction now. Yeah. Would you say that's the same for maybe a general urologist who wants to do more gender diverse patients in their practice, but is looking for some advice or has a problem come in, they've got a canal stenosis or a fistula, and they're like, I want to know how to triage this patient and get them what they need. Obviously, those are specialized things that the surgery should be happening probably with someone who's doing gender affirming surgery all the time. But triaging those patients or having a patient come in on call or even seeing someone in the office and kind of knowing what the next steps are for workup may still be something that happens in the community before they get to you. So would you say that the community, of reconstructionists is open to, advice from that direction?
In my experience, yes. I'm not going to speak for everyone, of course, but I'm always willing to talk to somebody, and everyone that I've ever spoken to who does gender surgery is more than happy to have those conversations. We want patients to get care as close as possible to them and to have as few barriers to getting the care they need. And so it's a lot better for a patient if we can have a phone call and tell you what you need to do to manage an acute problem, as opposed to transferring that care to a much farther away center.
Yeah, no, hearing your answer, it seems almost like a silly question, but I do think it's important for people to hear that, that like you want them to reach out, you want to, being a force multiplier as a gender surgeon, I think is probably, an even better way to improve access to folks. So I think it's good to kind of say it out loud, even if it's something that, even as I ask the question, I'm like, of course he's going to want people to reach out if they need help.
Yeah, I mean, it feels silly to have to say it, but you're right. I want to be respectful of other people's time, and they want to be respectful of mine. So they might not want to reach out because they don't want to bother me, but please bother me.
Yeah, all the things that we do, I think that there's probably not a better reason to be bothered than helping patients. So it's a good reminder, I think. Let's shift gears a little and talk about something that I think every listener can relate to. Most urologists will encounter transgender or gender diverse patients, whether it be for kidney stones, incontinence, BPH, for other reasons, even if they're not performing, gender surgery or gender affirming care. For the general urologists, what are some core principles to providing competent and affirming care for patients with gender dysphoria or those who have had gender surgery?
Yeah. I think this goes back to something we talked about a little bit ago, which is making sure that you're acknowledging and affirming someone's gender. So using their preferred name, using their preferred pronouns. But ultimately, when it comes down to it, transgender and gender diverse persons are people just like the rest of us that have regular human problems. And if they're there to talk about their kidney stone, they're there to talk about their enlarged prostate, they're there to talk about their kidney tumor, we don't need to ask them questions about their gender dysphoria. We need to focus on the problem that we're there to help them with.
Yeah, I mean, that makes sense. Compartmentalizing, problems is something that we do in every other facet of medicine. As a reconstructive urologist who treats strictures in my practice, I relish the opportunity to not talk about someone's PSA. So I suppose it makes sense that, if you're treating someone's stones, not talking about their gender dysphoria is honestly, it probably is a bigger deal in the head of the urologist who just wants to get it right than it is in the head of the patient who just wants to talk about their kidney stones.
Yeah, exactly. So just keep questions about it focused on clinically relevant things. So you're going to do endoscopic surgery, then you need to know what their anatomy is. So you need to know if they've had any gender affirming surgery so that you can properly access their bladder and their ureter. But you don't need to get their full history of how long have they been on hormones, how long have they socially transitioned, because that's not relevant to that care that you're providing.
Okay, and I think that's an easy kind of rule of thumb to live by. You're going to be treating gender diverse patients the same way you're going to be treating every other patient. If a surgical, historical point like a vaginoplasty is relevant to being able to get a cystoscope or ureteroscope in, it's pertinent. Another thing we hear from colleagues is, some uncertainty about screening and preventative care. What should we be doing for prostate, cervical, urinary tract screening in gender diverse patients?
We need to be doing the same screening that we would be doing for any other patient. I think one helpful way to think about it is to do an organ inventory and be aware of which organs a patient has. So if a patient has a prostate, whether or not they've had a vaginoplasty or not, they still need to be doing prostate cancer screening. You do need to be mindful that they've probably been on estrogen therapy for a period of time, and so their PSA should be suppressed. And so if their PSA is elevated, then they by definition have hormone-resistant prostate cancer. So that will affect how we treat them. But from a screening perspective, they still should be doing prostate cancer screening at the same time interval and the same age frames as your cisgendered patients. I'm not a gynecologist, but if they have a cervix, then they should be doing cervical cancer screening at the same rate. From a urinary tract perspective, you're still going to screen for microscopic hematuria the way you would screen someone who hasn't had gender affirming surgery.
Okay. And anything specific from, you bring up hematuria, say you've had a phalloplasty, I have certainly heard mentors who are like, if a phalloplasty, if the patient is emptying their bladder, if they're not having any lower urinary tract symptoms, like don't stick a scope in, a neourethra specifically to avoid, complications and strictures and fistula. Does the same thing go? Do you use a ureteroscope? Like, is there a change there?
Yeah. So our transmasculine patients who've had surgery, they're going to be a little more challenging to manage in this area. So a metoidioplasty patient, their urethras are often the smallest. So you're probably not going to get a flexible cystoscope in. And if you need to look in their bladder, you're probably going to need to use a flexible ureteroscope or a pediatric ureteroscope. I've not personally used one, but I've also heard you can use a hysteroscope, but I've never seen one. And then phalloplasty patients, my general approach is the less trauma, the more gentle we can be, the better. So certainly you could use a flexible ureteroscope, but sometimes the urethra can easily accommodate a flexible cystoscope. And if they need to be screened, they need to be screened. We don't want to miss a bladder cancer diagnosis in somebody because they had surgery.
Absolutely. Okay, so we've talked about the present. What about the future? Where do you see gender affirming surgery in urology heading in the next 5 to 10 years?
I think in the next 5 to 10 years, we're going to see a lot of innovation in this space. We're starting to see a lot more academic centers doing gender affirming surgery, which means I think we're going to see a lot more research. I think you see the proof of that already at meetings like the AUA and WPATH, where there's just increasing amounts of presentations and posters and abstracts focused on gender affirming care. I think one area that people are working on right now is patient-reported outcomes. We don't have a lot of good patient-reported outcome measures for our gender affirming surgery patients. And so researchers across the country and the world are working on that. I think there's also some issues that we have for our patients that we need to address. We've talked about hair removal, but we've not talked about how much of a barrier that is for patients. So hair removal is often not covered. It's time consuming and can be a major issue for why people can't get a vaginoplasty. So looking at alternatives to scrotal skin for lining the vaginal canal is something that I think we're going to see an increasing amount of going forward. I think also as we have a group of patients who are on puberty blockers grow and mature into adulthood, we're going to start seeing novel techniques to deal with decreased genital tissue when we're doing these surgeries. And then from a masculinizing perspective, I think that we don't have a great prosthetic to put inside of a phalloplasty. We're using the existing devices, but I don't think anybody thinks it's an amazing option. And I think everybody would like a better device to put into a phalloplasty for sexual intercourse. So I think those are some of the spaces that we're going to see innovation. And I think that you can't always predict what other innovation is going to happen. And that's what's exciting about it. So we'll see.
Yeah, absolutely. I mean, even as you're talking about a couple of those things, I know that I've seen work from a research standpoint talk about new and various linings for the vaginal canal for folks who are getting vaginoplasty, and even think about the patients who are going to kind of age into whether they want gender affirming surgery or not, are then going to have, been on puberty blockers potentially and not have that same tissue that someone who, is getting surgery later in life would have had. So that's a kind of a thought that I know I've seen before. And then the prosthetic question, at least at the University of Washington, we were using, two-piece inflatable penile prostheses when they were available because of kind of the logistics of getting a device into a phalloplasty. And I think that we're at least the company who was making the two-piece is running out of them. So there's got to be hopefully some innovation to make an inflatable prosthesis that might work better for a phallo.
Yeah, I know there's a device in Europe that is specifically for phalloplasty patients, but it's not, as far as I'm aware of, available for use here in the United States. And I don't know if it 100% handles the complications that can come with the surgery, like erosion and device fixation. So even with a device out there in Europe, I don't know I still think there's probably room for research and innovation there. I also think that back on the transfeminine side, we over the last, at least while I've been training in medicine over the last decade or so, I think we've talked a lot about female sexual health and vaginal health, and I think we need to bring that interest into the neovagina and what is the role for probiotics and other vaginal health products to take care of neovaginas. I think we don't know a lot about how to take care of the vaginal health long term.
Yeah. Especially, Rachel Rubin's done some amazing work on, genital urinary syndrome and menopause. I actually I don't know if you saw an email from the AUA about the black box warning being removed.
Black box is gone for the vaginal estrogen, which is great.
Exactly, which is huge. But you're right that is a kind of an untapped area in the neovagina. What is the best way to maintain appropriate health in the neovagina, which honestly will be a moving target as we talk about, non-genital skin replacements for a vaginal canal. Even that may be kind of a substrate specific thing. So really interesting area of research.
Yeah, and there's a lot of things that our patients do, whether it's douching or probiotics or other vaginal health supplements that they're doing based off of the experience of members of the community, but we don't know if they're helpful or harmful or neutral, and we need some evidence to tell our patients, are you wasting your money, or is it a good use of your time and effort and money?
Yeah, absolutely. Do you see, we've talked about a bunch of different ways that folks in the community, not in academic centers, not at specialized practices, can integrate gender care into their either broader reconstructive practice or even general practice. Do you foresee that happening?
I think definitely more urologists who are more reconstructive urologists are going to integrate gender care into their practice, especially as we're training more people with this skill set. It'll be more realistic to have gender care as a portion of your patient population as opposed to the focus completely. And then for general urologists, I don't know. I really don't know. I would hope that more general urologists will want to offer gender affirming orchiectomies or testosterone replacement or Testapel for gender diverse patients. I think as people get more exposure in training and more comfort with offering this care, that they won't even think of it as a unique part of their practice. It's just part of being a general urologist. But until we get, 10, 15 years down the line, I don't know.
Yeah, absolutely. If you look at we've talked about kind of the exciting amount of, change and growth that we've seen in reconstruction. You'd imagine if it continues on this curve, then in 10 to 15 years, we're not going to be having, an episode about gender diverse care. It's just that, it would be like having an episode about, cisgender care. It's just like what we do every day is the hope,
Exactly. We'll have an episode about what are the newest innovations or updates in gender affirming surgery.
Exactly. Any, last advice or parting words for listeners at home, whether they be students, residents, fellows interested in pursuing a career in gender affirming surgery or gender affirming care, or, urologists in the community or in practice who want to integrate more gender affirming care into their practice? Any words of advice for folks?
I think the one thing I'd want to leave people with is that this is some of the most rewarding, if not the most rewarding work that I do. To try to give a comparison to some of our cisgendered patients, the satisfaction that I get and the response that my patients give after a vaginoplasty or a metoidioplasty is very similar to the reaction from a post-prostatectomy stress incontinence man who just had an AUS and it changed his life. It's really some of the most rewarding work that you can do. And so if you're thinking about doing it, you should try and do it and find a mentor who can guide you on the pathway. Reach out to somebody and we'll help you make it happen.
Yeah, that's a pretty high bar, at least in my practice, or maybe a high standard. But I mean, if that's the kind of patient reaction you're getting. Those are, I routinely tell folks who are interested in like an artificial urinary sphincter that AUS patients are the happiest patients that I have in my practice. If your practice is full of folks who are giving you that kind of reaction, I think that's a pretty strong motivator from a wanting to integrate this in your practice standpoint.
Yeah, I mean, absolutely. I don't do it for the love, but my gender diverse patients are my most appreciative patients. And at the end of the day, that makes you feel good.
Yeah, absolutely. Well, thank you so much, Dr. Walton, for joining me on BackTable Urology. It's really exciting to see how, your early career has been progressing, what you see for the future and what's still to come in gender care and urology. So, thank you so much for your time. I really appreciate it.
Yeah, this was fantastic. I can't wait to do it again in a few years and talk about updates.
Love it. Can't wait.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Deng.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.